Unlike the juniors, I've actually worked with pretty much everybody here. So I don't need to introduce myself today. I don't have any disclosures. I stole this slide from Dr. Drew Lansdowne, mostly because I really like this video, which is pretty ugly. You know, when we're talking about ACLs, this is one of my favorite topics, certainly one of my favorite surgeries. I particularly like revisions. You know, I think we all know it's the anterior translation and rotational control as well. And, you know, in terms of the significance, I think really there's the short term and the long term. And so we've got to just remember we're returning patients back to surgery, back to sports, but we're also trying to reduce their risk of arthritis. Now, I've been asked to put in a slide addressing diversity, equity, and inclusion. I did do a search on this, and actually the biggest sort of most important study that I could find was this one out of the JBJS. Actually, this is a Kaiser population. Ron Navarro actually serves with me in one of the committees at the COA. He's a Kaiser doctor, and he put this together. And interestingly, a large study, but really showed that Asian, Hispanic, and Black patients have similar or lower risk of undergoing elective revision. This is for ACLs when compared with white patients. And they couldn't fully describe why, but that this needed more study. So something interesting to think about. I think there's some sort of key issues around ACL anatomy. You guys should be pretty up on what the anatomy is, but you know, you've got to remember there's the two bundles, and the bundles are named according to their tibial insertions. And I think generally just remember the anteromedial bundle controls AP stability more, and the posterolateral bundle is the key one for rotational stability. You know, I see this question frequently in the exams. The two bundles have essentially different flexion and tightness characteristics. So, different tightness characteristics. Remember, anteromedial bundle, tighten flexion, posterolateral, tighten extension. Sorry, I'm having problems with the slides today. Here we go. So, what are the important history questions? Give me 4 important history questions. Sachin. Just 4 points you want to know. You're thinking ACL. What do you want to know? 4 key points.
It's the mechanism of injury, the timing of the swelling.
Okay.
Ability to return to play. I'm assuming the person had this injury while playing. You know, people talk about the pop. I don't think it's not the most reliable thing, but I would definitely ask about that as well.
How reliable is it?
70%.
70%. Good job. So yeah, I basically like to know these things at a minimum. You know, first of all, I want to know if this is a previously compromised knee, but you know, were you able to keep going? Did the knee swell immediately? Did you hear the pop? And I like for just, you know, just to understand where they are, if they actually feel unstable now, because some will just say my knee is completely unstable. So that just gives you a distinct indication that, you know, that's what you're looking at. And, you know, 70% is the number, and that's correct. And it's usually a non-contact injury. Remember that as well. So what about the exam? Let's see. Alex, tell me about what are the 2 exam tests you want to look at.
You can do a anterior drawer Lockman obviously being a little bit more sensitive. And then you can do like a pivot to kind of pivot.
Okay. So let's talk about the Lockman. You guys, I think, should all know, you know, the grading system. I think that's something that is always asked, pretty straightforward. You know, remember to have the knee at 30 degrees for the Lockman, and the grading system A and B endpoints and your translation. I think it's actually kind of hard to get a good sense of what's 5 millimeters versus 6 millimeters. But nonetheless, that's the system that's out there. And I think after you examine lots and lots and lots of knees, you just get a sort of internal neurological ability to tell how far this thing is going. It's difficult sometimes if the patient's guarding, if they've got a big knee, but it's an important test. And, you know, it's that and the pivot shift are the key ones, right? So what causes the pivot shift? Hoha.
The pivot shift is that when you're in flexion, you'll see that the tibia is anteriorly translated, and as you put it out to extension, then becomes reduced, so that it either causes a glide or a clunk.
This is probably one of the worst ones I've ever seen.
Yeah.
That's a clunk, right?
Yeah.
But what's actually causing that tibia to reduce? What's pulling it back like that to make it clunk?
Just sort of the position. I guess maybe I got it mixed up. I think it's the positioning of the knee when you're flexing it up.
Yeah, so there's actually a structure, specifically the IT band.
Oh, right. Yeah.
Yeah, when you're in extension, it's actually keeping your knee, your tibia anterior, right? And then as you bend the knee, the IT band comes down and becomes a posterior force and actually pulls that tibia posteriorly. And that can happen in a clunk, it can happen in a shift, and it can happen in a glide, right? And this is a very imprecise grading system. I don't think that, you know, you'd be examined on specifically what the grading system looks like, because everybody uses something different. This is the UC method: glide, clunk. In fact, we don't really use shift even. 1+, 2+, 3+, depends on who you read, who you follow. But the key to remember that this is the most specific test for ACL, and that's a specificity of a 0.98 is pretty good. And really the key concept is basically the Ligament is the best test to diagnose ACL injuries, but the pivot shift is sort of the most sensitive test. And so if you're looking at really the results of your surgery, how good you've reduced that rotational component, you want that patient to not have a pivot shift. And we see that. We see patients who have actually a little bit more anterior posterior laxity, but no pivot shift, and tend to be doing well. So just remember the differences between those two concepts. Okay, Monica, what are we seeing here?
So it's an AP of the knee. Looks like there's a Sagan fracture on the lateral.
Okay, so that's the only really pathognomonic X-ray finding. You know, there's other associated things that we see with ACLs. And then when we get the MRI, remember always to look at the bone bruising patterns. I have seen a question where they didn't show a cut through the ACL; they just showed the bone bruising and you know, implied basically that what's your diagnosis. So remember, the bone bruising is a key part of that. And then obviously your MRI cut through the ACL will show that lack of ACL there. What other imaging do you want to consider, Michael, with your ACLs?
Yeah, so you want to look carefully at your menisci, particularly the lateral meniscus. Make sure that you're not missing a concomitant tear. Okay.
Yeah, no, I was getting at maybe some other X-rays you might order when you see an ACL patient.
Oh, I see.
So in sports medicine, you always want to have the backup answer of alignment films, right? Alignment films are a good backup answer when you're asked a question in sports medicine. So we don't do this, and actually some groups do, but very few. We don't do this for primary standard ACLs, in which we look at the patient and we look at them clinically and don't think they have significant varus or valgus. But certainly in probably every revision, you should be getting long-standing films. I think anytime you look at a patient clinically and you ask them to sort of stand and put their legs together, if you have any concern, you should get alignment films. I think that we look at that, you know, more and more carefully nowadays, because fixing an ACL in a person who doesn't have the right alignment and not taking that into account is a cause for failure. The other thing we look at on the X-rays, I think, again, when we're looking more at revisions, is the slope. You've got to understand the slope is key. Let's see, Alex, Why is the slope important?
I mean, this slope's important because it affects basically, like, so say you have a very increased tibial slope, obviously that's going to put more strain on your ACL, make it more likely for the kind of tibia to sublux anteriorly. So something to kind of just consider when you're, planning.
So let's say you had a high slope in a primary ACL. Would you do an osteotomy?
Probably not.
Yeah, I don't think any of us do that in the primary scenario. I mean, I've not seen a slope high enough that made me, really consider that. However, when you look at the revisions, that's when you start to think, okay, why did this ACL fail? If everything else is normal, why did this fail? And if the slope is really significant, I think you might want to have a second thought about that. So always remember the slope is an important component to all of this. Okay, so treatment decisions, fix it or don't fix it. Generally, we're looking at the higher activity, cutting and pivoting sports, higher demand jobs, physically demanding jobs, younger patients as operative, and then, the non-operative treatment is sort of the lower demand patients. So Andrew, in your broad, Figoni, in your broad sports experience, how many times have you seen a patient with an ACL tear that didn't get surgery?
Not that often. I think by the time they're coming to see you guys in sports clinics, they've already, most of the time they're coming with a diagnosis and they're coming with an idea of what they want to do. The majority of the ones I've seen in clinic end up getting it reconstructed. I think at the county, it's probably a little bit different. We've got different patient populations, so more of those patients aren't necessarily getting it reconstructed. But I mean, it obviously has to be a shared decision making with the patient, right? No one needs their ACL reconstruction. You can function with doing day-to-day things, but if people want to get back to pivoting activities or skiing or snowboarding, things
so
like
does having an ACL injury prevent people from getting back to lower demand sports?
No, I mean, they can brace, they can use, you can do training to help kind of strengthen the surrounding musculature, and you can do kind of activity modification for certain sports and activities. The time that you would potentially want to recommend surgery is if they're doing those things, but they still feel like their knee is unstable. But always a patient-surgeon discussion, not an absolute indication.
Yeah, shared decision making, right? So I think that this is also somewhat regional, right? I talk to my friends in England that are sports physicians, and they're always horrified by the amount of ACL surgery we do because, there and in Finland and various other parts of the world, I think they're a lot less aggressive about the surgery. They're a lot more likely to recommend conservative treatment to start with. And there is some data to suggest that, actually patients can do quite well without surgery. I think we're not just us as surgeons, but our patients in general are fairly well primed to consider surgery. I think there's just a couple of points that you guys all need to know about if you are going to go towards. So just remember, not everybody needs surgery. And secondly, if they do have surgery, we still don't have the data to prove that doing an ACL reconstruction reduces the risk of arthritis 5 to 10 to 15 years after surgery. I think we all believe that probably helps, but there's no study that proves that yet. We do know that not having the surgery does lead to higher concerns regarding your meniscus and cartilage. And so, that's something that has to be shared with the patients. And this other question, I don't know, have any of you seen a double bundle repair, reconstruction? No, I don't think, I did a few when the concept was hot, but I think it's gone out of favor. And I think that the answer to that question is really that it's no better than what we currently do. So those are some,
Technically, how is that different?
what's that?
Technically, how is that a different surgery?
It's much
We just
more
don't see any of it.
Yeah, it's much more complicated. You got to drill, 2 sets of tunnels. You've got to make sure that they don't, that they don't converge. It increases the length of everything, the surgery time, the cost, everything. If you ever listen to Freddie Fu talk about it, it was very convincing. But it's one of those things that the theory and the practice don't really mix well. So I think that it's largely gone out of favor. I don't know anyone who does it at this point in time. And I don't know anyone who really did it a lot when it first came out either, other than obviously the Pittsburgh people. All right, tunnel placement. Okay, Laura, how do you like that tunnel?
Looks pretty anterior.
Pretty anterior, okay. Where would you rather put it?
Much more posterior. You want to be just off a couple millimeters off of the posterior femur, essentially, if you're looking at drop.
Yeah, so I can tell you on this one, this is one that resulted in a lawsuit, huh? So don't put your tunnels there. What about this tunnel?
Super vertical.
Okay, is that entirely wrong?
I mean, you see higher failure rates, I think, with vertical tunnels.
Yeah, so it's interesting. The old method of doing these, we did them all transtibial. We put in a lot of vertical tunnels, and interestingly enough, many of those patients did well. And I think that that's because they still had secondary restraints that helped them. But the bottom line is that those tunnels are too vertical. It's not anatomic. Okay, so Erica, here's a video of a revision. Okay, tell me what you think of this tunnel placement. You can see the screw there, right?
Yeah, it looks pretty anterior.
Yeah, it's ridiculously anterior. This is just really. I mean, there's a mile of room back there, right? This is where your ACL should be. So these are just examples of what we see, and I think these concepts are pretty, sort of pretty well described already. You guys should be pretty familiar with them, where the bundles attach. And where you want to basically, this is your target zone here. But I think one of the key things to remember, this is the description and the anatomy when you look at it on the screen of the knee in extension. This is what it looks like in extension. Remember when you're actually scoping these knees, that this is bent down and this is what it looks like now. So you want to just be cognizant of the fact that this anatomy changes as you bend the knee. And so importantly, just make sure you get that in the right place. And this I just had to show. So first of all, we all know about Residence Ridge here, right? And that's got an official name. But this is a slide that Christy Allen used to always show with a little triangle of where you want the ACL to be. So I just had to throw that in there because she's no longer with us, and I know she would have wanted to bring that up. So remember also that your viewing portals, I always probably have told many of you guys, one of the other answers when you're doing arthroscopy, when you're asked a question is, what about switching portals? It's either use the 70-degree scope or switch portals. So remember that things look a little bit different from the anterolateral portal. You can kind of see that insertion reasonably well, but when you go anteromedial, you've got a much better look. So just some little tricks. And again, remember that's at 90 degrees of flexion. But there is, and you guys can look this up in more detail, there is radiographic criteria as well. We always know that, yeah, it's right about here that we want to go. But there is some radiographic markers that can help you with that if you're concerned. And on the tibial side, this is the Amos-Jacob line, and 43.8% is supposed to be the center. We typically use the concept of quadrants, and you want to be in the second quadrant. But you have to be careful with these. for knees that are in hyperextension. Okay, so if you look at this knee, your line coming up here for the tibia should be in line or behind Blumensatz's line. But if you look at it, if you were to do that with a hyperextended knee, that tunnel should be over there, which is too posterior. And the problem here is this knee is in hyperextension. So it's got to be taken at 0 degrees of extension. And the radiology techs at the OI are really good about getting that right, but always just be sort of a little bit wary of the knee that hyperextends. Okay. Let's see. Gopal, why don't you answer this question for me?
Sure. So without a history of significant re-injury, a 22-year-old student reports recurrent instability 1 year after undergoing autologous patellar tendon ACL reconstruction. A radiograph is seen in figure 147. What is the most likely cause of the injury? So 1, varus alignment, hard to evaluate on this lateral or lateral radiograph. 2, tunnel malposition. We talked about some of the factors being the femoral side being more posterior, and then the tibial side I am concerned about based on the position of that screw, but I'll go on to 3. 3 is failure of biological graft ingrowth. The timing is 1 year after undergoing autologous patellar tendon ACL reconstruction. So I would suspect that it healed, and then it sounds like it happened a year later. So that makes me not favor that response. 4 is failure of bone healing at the tunnels. I don't see any clear evidence of that radiographically. And again, the timing I think is sort of cluing me into a delayed failure. And then 5, unrecognized posterolateral corner injury is. I don't see any evidence of that based on the question stem. So I'd pick 2, tunnel malposition.
Yeah, I think actually this is a pretty easy question, especially when you look at the X-ray, right? I think they're giving you this one. And the tibial tunnel is way anterior. The femoral tunnels, and yeah, it's a bad lateral to start with, but it's clearly not posterior. So I think that when tunnel position is the #1 reason for failures, so they do ask that question a lot, and it's something just to remember as #1. All of these other things, of course, can cause it, but it's the #1 reason. What range of motion does this patient have, Gopal? Or what would you suspect based on this?
So it's 2 anterior, so I would suspect limited flexion, like they wouldn't be able to get to full flexion.
Yeah, also so that probably they work through, but many of these patients develop a lack of full extension because they're impinging on the roof, and ultimately then that sort of breaks down the ACL and they fail. So,
I see. Okay.
But just always remember tunnel position #1 in your differential diagnosis. Okay. And yeah, just to belabor the point, another question, same thing. Okay, malposition tunnel, always remember that. What about associated injuries? Because ACLs, I think I did one 2 weeks ago, which was just a pure ACL, but that's actually uncommon, right? What are the concerns with meniscus injuries? So, this is often a pimping question in conference. You guys have probably all heard it. Acute ACL tears, lateral meniscus tear. Chronic ACL insufficiency or chronic ACL tears, medial meniscus. I've seen that on the exams. It comes up, so you guys should all know that. What about the lateral meniscus, right? I think that we almost always repair the medial meniscus if it's torn at the time of the ACL. Can we leave it alone? Let's see, who's up on my list here. Let's say you have an ACL tear and you have a small lateral meniscus tear. Alex, can you leave it alone?
I mean, you do get improved meniscal healing rates if they're done at the time of ACL.
Yeah, that's true.
Supply. So there's a small chance that with So there's a small chance that just because of the environment in the knee that you're going to have a little bit of a better healing rate if, you just leave it alone. So if it's small and, maybe you could get a better healing rate, but I think because it's documented you get better healing rates, I feel like I usually see people trying to fix it if they can. You're in there. It's not that hard to try to fix it.
Yeah, and the results are good, right? This is an example of, you get good results if you do the repair, but actually there's, some interesting data, good data basically, that suggests that if you don't repair lateral meniscus tears, and again, let's focus, this is very specific, lateral meniscus tear, the Moon group has shown that as long as they're small, they actually can heal. So just be aware of that. It's not, I think that we all tend to be aggressive about fixing anything that's in there, and I personally don't change my repair pattern based on this data, but the data is there, and it clearly also indicates, of course, you've got to repair that medial meniscus.
Would you be more likely to say leave it in situ or repair it depending upon pattern? Like obviously, if it's like a radial tear or something like that.
Very, very much so. If it was a very small vertical tear, and I have done this rarely, but if it's a very small vertical tear, I will leave it alone if it's right way back in the red zone there. If it does not feel unstable in any way, but most of those, even if there's just some question about it, I'll just shoot a true span across it and not have any concerns for the future. But that, again, this is just something to remember, that there is data to show that small lateral tears probably don't need to be repaired. What about cartilage? Sachin, you go in on an ACL and it's got a 1.5 by 1 full thickness cartilage lesion, 22-year-old. What are you going to do?
Yeah, I actually think I'd probably be inclined to leave it alone and then see sort of longer term what happens. And there's certainly some benefit from, like, if I'm doing an ACL, I'll probably, in my practice, be microfracturing the notch anyway. So some growth factors from that as well.
Okay. Are you microfracturing the notch in ACLs?
With the meniscus? Oh, sure. Without a meniscus tear, just a cartilage lesion.
We're just talking cartilage now.
Oh yeah, no, I'm not routinely doing that.
Okay, I was just curious. So leave it alone, huh? Anyone else want to do something else? And let's just talk basically about leave it alone, debride it, or microfracture it. Anyone want to do something different? So I think, again, this is very surgeon dependent. I'd probably be at a minimum just debride it, any loose edges. A smaller lesion, under 1 centimeter, I would probably actually microfracture just because we're there. I think we get this idea that we want to do something. But again, the data is really not that clear that doing something will make a big difference. If you look at all of these groups, their outcome studies at the end of the day are all kind of similar across the board. And so I think that, you have a choice here, understanding that the reality is that it may not make a big difference. And the question about, doing something later, I think is very valid, Sachin. I think that's something that we probably practically are far more likely to do, is keep a close eye on that patient and kind of consider a second line surgery if we have to. What about the MCL? Monica, I'm rotating around back to you. You have an ACL tear, patient has an MCL tear. Do you fix it or don't you fix it?
I think MCL tears you typically let heal on their own. So you can either do allow time to let the MCL tear heal if it's like a lower grade injury. and then kind of do the ACL after that, to kind of let it not interfere with their rehab. Yeah, I think in general.
Okay, I agree with that. So this is a patient of mine I saw 2 weeks ago, came in with an ACL tear and a clearly grade 3 MCL. Okay, this was her MRI. And what's your approach for this patient?
I think a grade 3, like, tear, I would consider doing a MCL repair at the same time as the ACL reconstruction.
So where is this MCL torn off?
Distal.
Distal. Okay. Is there a difference between a distal and a proximal tear when it comes to outcome?
Yeah, I think distal tears are generally more challenging than proximal tears to address. And so I think a proximal tear is like, I would probably think more likely trying to repair it. So I guess a distal tear, I would maybe try to see if it could heal on its own with like immobilization.
I think actually the general feeling is the opposite.
Opposite, right?
Sorry. Yeah, that's okay. You know, I think that the problem with the distal tears, and there's some theories around the concept that synovial fluid leaks down there and prevents it healing down. Proximal tears tend to heal, even if they book open to a grade 3. You might suggest you know, non-surgical treatment for the MCL specifically, so fixing the ACL and not fixing the MCL, just bracing them. But I think the general sort of practice is that there's not a specific reason to fix the MCL. Typically, timing is the real question. Do you let them get better first? You know, brace them and let them get all their range of motion back? I think that's a little bit variable between surgeons as to how they do it. I personally like to see my range of motion come back completely before we do anything. So most of these patients will get braced and rehabbed, and then we see what happens after that. But I do think that the distal ones are really concerning, and those ones almost certainly will need a repair and you know, need surgical treatment of the MCL itself because it doesn't like to heal. So just be aware that the distal MCL tear is a bit of a different animal to the typical MCL. Okay, graft choices. Graft choices. So you guys should all be very familiar with this graph of grafts. Cutoff, you know, depends on when you want to, where you look at this curve. 35, 40. I use 40 per most of the time. Sometimes I'll cheat down into the late 30s. And you know, if you are going to use autograft, what autograft do you use? Well, I think we've all got historical preferences, but understand that this data, which is what, you know, most of us go by, the sort of regular understanding is that there's not a big difference between BTB and hamstrings. Okay, which is, you know, we're not talking about quadriceps here, which I think is sort of going to be added to this discussion down the line. But for the traditional treatments, BTB versus hamstrings, there's not a lot of difference when you look at the older data. What is coming out now is that there's sort of, so look, if we look at the generally accepted conventional wisdom, you know, 35, your cutoff for allograft. If you're going to use autograft, you can use either one. Re-tear rates are similar. However, what we are finding, and this is sort of a recent study out of the Moon Group, is that we are seeing higher rates of revision in autografts for those that are done with hamstrings versus BTB. And their number is 2.1 times the incidence. Now they're looking at, and this is for a specific population group, younger, more active, contact sports, things like that. So the 2.1 number is very concerning. And I think what you're finding is that certain surgeons are going back to using BTB grafts for that specific group of patients. I think the exam answer is still that there's no difference, but just be aware that there is actually now data showing that we might have to revise that thinking. And actually and I'll talk about it a little bit, but there are other sort of aspects to it that sort of tie into this concept that the more younger active patient might need to have something other than a hamstring graft or something in addition to a hamstring graft to give them a good outcome and a lower failure rate. So what about return to play? Let's say you've got a straightforward ACL, did a 22-year-old wants to play soccer. When are you going to let them go back? Hamstring autograft, Michael.
Yeah, so I mean, I know everyone's rehabilitation protocol is a little bit different, but I think in terms of graduated return to play, you know, you're looking at like 4 to 6 months, probably earliest. But also, I guess it depends. Do they have a you said just routine primary ACL, no meniscus repair or anything like that?
Correct.
Yeah, so
4 to 6 months. When does the graft actually incorporate and mature?
I'm
sorry.
I'm not entirely sure. I forget the time.
Yeah, so, you know, if you get a chance, look at or listen to Dr. Lansdowne's talks about ACL imaging. He's got some, you know, sort of really fun sort of viewing of the ACL, you know, by T1 row imaging that sort of is a little bit sort of interesting from the point of view of what we see and what we do. In other words, what we see is it takes 24 months or so for that graft to actually fully mature, okay? And wait a second, where's this slide? There we go. So, you know, we talk about 24 months for full maturity. Well, we're letting our patients go back to sport. Now, Andrew, I'm impressed you're sending your guy back at 4 to 6 months. I'm of the 6 to 9 months sort of return to higher level of sports. I think they can be playing golf at 4 to 6 months easily. But if you're talking about soccer or basketball, I'm not letting them go back to that for, you know, usually typically 9 months. Now, I'm on the longer side. I think some of the other surgeons you work with at the OI are going to be a little bit more aggressive. But remember that the graft maturation takes a long time, but that we're probably very comfortable letting our patients go back at about 9 months. It's still a little bit in the remodeling phase. But it's probably okay at that point in time. So a bit of a controversial question, but something to, you know, think about. There's no good physical tests at this point in time. There's a lot of discussion around that. It's still somewhat surgeon dependent at this point. You know, the 9 months to 2 years. So, okay, let's talk about failures. All right. We talked a little bit about tunnel malposition, but I think you want to, we've looked at sort of all of these, but if you want to look at a summary of why did the ACL surgeries fail, you've got to look at everything. Tunnel position is probably the most important, but, you know, remember to look at the slope and the varus, the alignment. Remember the meniscus deficiency, other ligaments, you know, particularly posterolateral corner. I think some of the kinematics of what they do is important. You've got to understand graft incorporation to some degree, and some of the future might be some biologics to help with that. Of course, the surgical side of it is, you know, probably key, and then obviously the patient side. So all of those things all sort of add up. Okay, so what's the future in ACL looking like? I think some of this is, pretty interesting. Erica, what is this surgery? Oops, sorry.
IT band tenodesis.
Okay. I think that's 100% correct. What do we typically
ALL.
call it?
I think you're trying to reconstruct the anterolateral ligament for those patients who are still unstable and drop after you do an ACL reconstruction.
Okay. What is the ALL? What is the anterolateral ligament?
I think my understanding, it's controversial. It's either a thickening of the capsule and or sometimes in some patients for the IT band.
Yeah, so I think for those of you who don't know the history, the ALL was famously discovered in about 2013, I think, or maybe earlier than that, and came out to great fanfare. But I think subsequent studies have really identified that it's more of a thickening of the capsule rather than a specific ligament. But it is where you see the Sagan fracture. And the idea is that the ALL is actually the ligament that attaches to that little bony piece that causes the avulsion fracture that you see that's pathognomonic for ACL. So the concept is that it plays some sort of a role in rotational stability. And soon after the quote unquote discovery, there were lots of papers and discussions, and of course industry jumped on the wagon and had an ALL reconstruction technique and specific instrumentation. And I think that is still something that's done. I think it's done a little less frequently. And there's a level of belief, in your systems, your belief system, whether or not you believe that's actually a real concept or not. I think there's some validity to it, but I think what's replacing it pretty rapidly now is this technique, which is technically far easier. And it's actually an old technique. It's done very many different ways. And it's called a lateral extra-articular tenodesis. And essentially, the more modern way that it's done is that it is an open incision over the IT band. The middle third of the IT band is essentially divided, and then tenodesed down to the lateral femoral condyle underneath the LCL. It travels under the LCL and then tenodesed to the lateral femoral condyle, and that provides a similar amount of rotational control that the ALL provides. This is a much easier, much quicker way of doing it. And so I think, we've started doing this in practice. And I think when you look at, the lateral side, this is probably going to be the way that it's done in the future. And there is some studies to show that it does reduce failure from ACL reconstructions. And so the concept that if you have really young active patients and maybe patients who, for example, have hypermobility and you want to do something extra in addition to your hamstring, you would consider doing an LET in addition to the hamstring to help them with rotational control. Also, obviously, very, very germane to the concept of improving your revision outcomes. So in a revision patient, you might think about an LET in addition to your ACL. And maybe in that situation where you've got the very young, very active patient, and you don't necessarily want to do a BTB on them, you could do a hamstring plus an LET and get an equivalent outcome. So I think those are all concepts developing that we're going to see lots and lots more of. So, this study, for example, showed 11 versus 4% if you got your LET, sorry, 4 versus 11% if you got your LET, basically a 65% relative risk reduction. So I think this is an important concept and probably something we're going to see a lot more of. It would be remiss of me to not mention kinematics, since both Dr. Lansdowne and Dr. Marr are very active in this field. There is this concept that the actual bone surfaces, the morphology of the condyles is important in looking at what fails and what doesn't fail when it comes to ACL surgery. So just be aware of this, and you know, I think we're going to await some interesting further studies on it. ACL repair. There's been an interesting sort of resurgence of the concept of ACL repair. Some of that's driven by DeFelice out in New York, who initially published on this, and this is his technique. Essentially, here's your ACL torn off the wall there, and you put some stitches across it, you get a swivel lock or equivalent device, and you stitch it right back where it used to be. Only for certain types of tears, only for proximal ruptures. Currently still being determined. You know, obviously this is a treatment that has gone through a cycle. It was initially tried, many failures. The concept is that by doing this and adding an internal brace, you stabilize the knee while it heals. DeFelice reports good results, but we are yet to see this broadly accepted. I think that's something, and maybe again with new biologics, something that might be of value. We'll see. Probably more likely is Martha Murray's device, which is this interposition graft that is essentially a blood-soaked sponge that's put in for primary repair. Again, this still needs an internal brace to hold it in position. She actually came out and gave us grand rounds and talked about this device. That's her with her first patient. And I think that, you know, the trials are now getting to the point where this is being commercialized. This is the technique. Essentially, buttons are placed on each side, and that sponge is drawn in and incorporated into the repair. So something to look forward to seeing, you know, sort of where this goes. I think it's at the point of commercialization at this point.